Bismillahirrahmanirrahim. So today we are starting with a new topic. I hope your Ramzan is going well and you are enjoying Ramzan as well as this distance learning program. Now the picture you see on this in the slide, I hope you have seen this patient like this begging on the roads. So what do you say? What it is? We are already discussing the leg diseases, so it's a disease of the leg, obviously. Now this is lymphedema. Today we'll discuss what are its causes and how we will investigate. We will discuss treatment in next lecture, inshallah. Now, lymphedema is due to some problem in lymphatics. Now, lymphatic system is, already consists of lymphatic channels and lymphatic organs. Organs are spleen and lymph nodes. Spleen, there is only one spleen and there are many lymph nodes throughout the body. Now, how lymphatics function, how lymph moves. Now, this again, it's a physiology, and you must have studied in your second year course. Here, just a bit introduction to this. That it functions with function of this lymphatic is return of all protein-rich fluid. Now, there are two spaces, interstitial space and vascular space. So there are some substances which are in the vascular which can cross the cell membrane and go to the vascular compartment, and there are some substances which cannot. So these substances are micromolecules, microproteins, and macroproteins. They are lying in the interstitial fluid. And function of this lymphatic is return of this fluid from the interstitial space into the vascular space. Now, how it functions? In the next slides. Now you see this the concept map of the lymphatics throughout the body. You can see everywhere there are lymphatic channels, and they are taking the extracellular, the interstitial, the lymph, the protein which is lying in the interstitial spaces, which has to be moved to the vascular compartment. Otherwise, it will give rise to swelling, which you have seen in the first slide. Now, movement of lymphs takes place through some forces. There are Starling forces. There is hydrostatic pressure and there is oncotic pressure. The balance between these both moves the fluid from the interstitial compartment to the vascular compartment, and then compression of the muscle moves it further toward the cardiac side. These micro and macro molecules move through either endothelial openings or through vesicular transport through endothelial pores. And large particles are actively phagocyted by the macrophages, as macrophages are also part of the lymphoid system. Now, what is vesicular transport? This picture you can well understand it, how these particles are engulfed and then taken inside. Now, there are many diseases of lymphatic system. There is infection and tumors and just lymphedema. Now, the most common one is lymphangitis, which you may come across. It's commonly found. So it is inflammation of the lymphatic channel. You will see patient with typical streaks like thrombophlebitis. There will be streaks of reddish lines, and ultimately there will be enlarged lymph nodes. If it does not control at time, it will lead to bacteremia and septicemia, which will be all inflammation feature, heat, fever, pain. Now, treatment is just give rest and elevate to reduce swelling, and give IV antibiotic. Now, this elevation is for especially upper limb, when there is acute lymphangitis, you will elevate limb so that there is the pain is reduced. Now, if it should improve in 48 hours. If it does not improve, it means that if the antibiotic is not proper according to the empirical organism which we are suspecting there, like Staph and Staph aureus, so it may be something else, and you have to then take culture for that presence of underlying pus. If pus is there, again, it will not be resolved. You have to drain that pus. And if there is some other disorder like there's malignancy or immunodeficiency, so it will not respond to the antibiotic only, then you have to investigate and find out the cause. Now we come to the lymphedema, which the picture I have shown you earlier. What lymphedema is, it's an abnormal lymph swelling caused by accumulation of increased amount of high protein in interstitial fluids compartment secondary to defective lymphatic drainage in presence of near normal net capillary filtration. That is, capillary filtration is going capillary or at the terminal end where filtration is going normally, but from there onward, either channels are not there or channels are defective. Now, what are those defects? We come to that. Now, what are symptoms in patients who are going to develop lymphedema? There will be obvious swelling, and patient may complain that my clothing or jewelry become tighter and tighter with each passing days, and there will be constant dull, even severe pain, burning and bursting sensation, generalized tiredness and debility due to as the weight of the leg is going heavier and heavier, sensitivity to heat, pains and needle sensation. Now these some sensations are related with the pressure on the nerves as well, cramping, feeling, and as the volume of the skin is going to increase with the lymphedema, so skin problem starts, and due to pressure on the skin, there's flaking, weeping, mean there's excoriation and oozing from the skin crackles, and as there is size of the weight of the leg is going to increase, so patient will feel tiredness and it will mobility will be slowly and gradually decrease, leading to obesity and muscle wasting as well. And these all weight gaining problems then lead to backache and joint problems, athlete foot, acute infective episodes. And athlete's foot is dryness and crackling foot. Patient will develop a crackle and dry foot. I put picture was not there. Okay, the athlete foot is like the foot will become dry, and cracks will appear on it. And then acute infective episode, because the skin is dry and it's oozing, it's very easily infected. So patient will get infection, will take some medicine, and again infection. So they are repeated. So these are presentation, general presentation of a patient with lymphedema. Now, a patient comes to you. So what are his concerns about why he comes to you? Because you will see many patients. We have seen many patients OPD with like swellings. They are not lymphedema. Mostly they are lipoderma. Lipoderma means that there are a lot of fat in their legs. But patient comes to find to ask why I am developing this problem. They ask for guidance on skin hygiene because skin is always scaly and get infected again and again. Antifungal prophylactic therapy to prevent athlete foot become dry and crackle, and it's easily infected by the fungi. If there is acute episode of infection, so patient needs to be admitted because otherwise patient will develop bacteremia and septicemia. Patient also needs appropriate instruction regarding exercise therapy. Manual lymphatic drainage is also performed because if there is a lot of lymph swelling, increased size of the leg, so there are some procedures to manually remove those lymph from those leg, and multi-layer lymphedema bandages to control this swelling, compression garments, and advise on diet and access to support service and other facilities. So these are the concerns of patient for which patient will come to you. We classify this lymphedema by mild, moderate, and severe, depending upon the lymph volume. That how much percentage lymph volume is more than normal limb. Usually lymphedema is unilateral, so you can compare both limbs and you can say that how much percentage it is more than the other. Now how it develops, how this lymphedema develops. First is abnormal capillary filtration and abnormal lymphatic drainage. If there is abnormal capillary filtration and if there is abnormal lymphatic drainage, so extra amount of lymph will accumulate in the interstitial fluid and will give rise to swelling. Now, as I told earlier, that lymphatic system consists of lymphatic channels and lymph nodes. So either lymphatic channels are defective or lymph nodes are defective. Now, what are the reasons of their defect? Lymphedema result from either lymphatic aplasia, hypoplasia, dysmotility, or obliteration by, like they are gone by some inflammatory process leading to fibrosis, infectio or neoplastic process, or surgical extirpation, like you have performed some major surgery and those channels has been removed or those lymph node has been removed. Like in breast surgery, when we do breast surgery, sometimes we also remove the or lymph node in the axilla. So when there's no lymph node, patient will develop lymphedema of the upper limb. Similarly, any pelvic surgery in which we remove the in one lymph node, again there are chances of development of lymphedema of the leg. And this then leads to lymphatic hypertension and distension, and with secondary impairment of contractility of these channels, and as there is dilatation of these channels, so there will be valvular incompetence as well. Now this is the area where these all processes occur. You can see the arteries, the veins, and then there's this space, and it ultimately the substances which cannot go into the vein, they go into the lymphatic system. Now, once this process is defective, process of lymphatic movement is defective. So what happened is, there are micro and macro protein substances like fibroblasts. So then they leads to increased collagen production, accumulation of inflammatory cells, macrophages, and other substances active. And then when these are inflammatory substances are there, so there's activation of keratinocytes and skin thickening results. And there is protein-rich edema fluid, increased deposition of ground substance. Ground substances, all these protein, they are fill up their substances, and there is subdermal fibrosis and dermal thickening and further proliferation. And when it thickens, it crackles, and there is breach of skin. And then again, all cascades of reaction, infection, inflammation. Now you can see, you can compare one limb is fine and other limb, you can see this all. Now you can well imagine the pathology behind this swelling, that there is either channels are defective or their lymph nodes are defective, or there is accumulation of all these substances which we have discussed, and then activation of conversion into collagen and fibrosis and further activation of keratinocytes, all substances. Now, interestingly, this lymphedema, like which you see, this lymphedema is just limited to the epiphyseal area. It does not involve the muscular area. And when you take, I'll show later on, there's CT scan in my slides, that it is just in the epiphyseal spaces. It does not goes to the, so muscle compartment is characteristically free of edema. When you take CT scan at the cross section, you will see that there is muscles are not hypertrophied, only epiphyseal area. There is honeycomb-like reticular area, which shows the lymphatic channels and field of lymph. Now we further classify. One classification was it's depending upon severity, whether it is according to the volume of the lymphatics, whether it was mild, moderate, or severe. Now, other classification is based on its etiology. Primary lymphedema and secondary, as the name indicates, caused by primary one is caused by congenital lymphatic dysplasia, and secondary is acquired, which has clear cause for it. Now, primary again is divided into two types: congenital and precox. Congenital up to age of 2 years and precox up to age of 35 years. No other cause. Like any lymphedema in which no other cause is found, is mostly due to congenital reasons, and then secondary or infections, fungal infection, exposure to foreign bodies, material like silica. Now, silica is a particle. The people who are the labor who are working barefooted in some areas, so in some factories with their silica. So these particles go into the dermal area and slowly uh, they impair the capillary and these lymphatic area in early phases. So the swelling starts from the foot. Primary lymphatic malignancy mean that malignancy of these lymphatic channels or lymph nodes, and then metastatic spread to the lymph nodes. If there is some other tumor spread to the lymph node, again lymph node will stop functioning, and when their function is impaired, there will be definitely lymphedema. Radiotherapy to the lymph nodes. Why radiotherapy? Like sometime in breast surgery, we do breast surgery, we do remove the breast, and we do not uh, remove the lymph node, but we give radiotherapy. So radiotherapy again can damage lymph nodes, and sometimes we remove lymph nodes. So surgical excision or radiotherapy, so they will give rise to lymph node dysfunction, and severe trauma, degloving injury in which all the lymphatics are gone with the skin. So again will give rise to secondary lymphedema. Superficial thrombophlebitis, there are a lot of channels along with these, they are going along these vessels. So when there's thrombophlebitis, so surrounding inflammation may involve the lymphatic, and secondarily lymphedema will develop. And similarly, deep vein thrombosis, again when there's thrombosis, there is compression upon these lymphatic channels, and their dysfunction is compromised. So these are causes. Now, why you should know these causes? Because when you take history, you should have these causes in your mind. Like a patient having lymphedema, so you will ask him previous history of hospitalization, previous history of any surgery, previous history of any radiotherapy, any trauma. So this is how you will reach to the diagnosis. Now, clinical features are subclinical, like malignancies, but it's not malignancy. But patient like underlying process of lymphedema is started, but it's not visible clinically. It's a micro level, and then there is grade 1, 2, and 3 when edema, pits on pressure, and swelling largely or completely disappear on elevation and bed rest. Now, at this stage, it's very confusing because edema pits in some cardiac diseases, and when patient elevates limb, so it disappears. So at this stage, it will be confusing that whether it's lymphedema or it's just edema. And then edema does not pit and does not significantly reduce upon elevation at stage 2. And when it does not pit and does not reduce on elevation, this sign is called stammer sign. And then there are, now it's stage 2, like it's grade 2, there is skin is normal, normal looking, but in stage 3 there is subdermal fibrosis and cracks, and these irreversible changes appear because there is transformation of fibroblasts into collagen and deposition of collagen, so it becomes irreversible at that stage. No other sign is characteristically involves foot, like it starts from the foot, it goes up to the knee, and rarely it involves the whole thigh and up the thigh area. Initially contour of the ankle is lost. You know the ankle is a beautiful contour of this malleoli on the right and the left, and then there is narrowing at that area. So this contour is lost. Buffalo hump forms on the dorsum of the foot. The toe appear almost square. Skin and dorsum of the toes cannot be pinched. Skin becomes as thickened. It spreads proximally up to knee level, and eczema and fungal infection appears. You can see this. This all fungal infection destroys the nails, and you can see this papilla like cracks. They appear and it's almost square. You can see this malleoli shape is lost. You cannot differentiate where it's malleoli clearly. And slowly and gradually, swelling appears on the skin. These are nodules because nodules are made up of these lymph which become fibrous. And then there's ulceration and raised purple nodules, which raise suspicion of malignancy. Lymphangiosarcoma can develop in any long-standing lymphedema if it is more than 20 years. Now, these are the lymph. If there's long-standing, anything long-standing, even long-standing mild irritation of the skin can give rise to tumor formation. So similarly, there's a long-standing process of fibrosis and repeated infections and swelling and hypertrophy of these skin appendages. So ultimately, that will lead to it may lead to the following tumors: lymphosarcoma, lymphangiosarcoma, Kaposi sarcoma, squamous cell carcinoma, liposarcoma, malignant melanoma, malignant fibrous histiocytoma, and basal cell carcinoma and lymphoma. Now, if you reread these all structures, so these are tumors of the structures which are anatomically lying at that area. These are like skin appendages, and then they are these are all they're all basic unit cell is lying in the cell, so it will give rise to tumor of uh, those substances. Differential diagnosis of a swollen limb. Patient will come to you with a limb. It may not be, it may be typically the picture you have seen earlier. It may be generalized, a smooth swelling. So how you will know whether it is lymphedema primarily or it is something else? Now you know the patient may develop leg swelling from the cardiac causes, from the renal causes, from the hypoproteinemia, from trauma, from vascular diseases, from DVT, deep vein thrombosis, and many other causes which we just discussed and lymphedema. Now, what does it mean 1000? 1000 does not mean 1000 causes. 1000 is a page number of Ballet if you want to visit that. All the list of that causes is given in that page. A typical lymphedema you can see. There are different causes of lymphedema. Once again, they due to trauma, lymph node excision, radiotherapy, burns, degloving injury. We have discussed varicose vein surgery. If there is some barbaric surgery has been performed, and large circumferential wound, because as I have told you that they are mostly lying in the epiphyseal area, so they are very easily are removed. The malignant diseases of lymph nodes, metastasis or primary disease, venous diseases, infections, inflammation, and endocrine diseases. So these all may lead to, these are all causes of just repetition of the previous slides. Now this is a lymphangiogram. You can see, you can compare on the both side. On the left side, there are beautiful channels, there are many channels of lymphatics, but on the right side, there's only one channel. So we can say it's a hypoplasia, hypoplastic type of, it may be congenital. Now, among the other, among the all causes, is filariasis. Filariasis is the most common cause of lymphedema. It's a nematodal infection caused by Wuchereria bancrofti and spread by a mosquito bite. This is common in African areas and South America and some Indian areas. And due to poverty and poor sanitation, the immature parasites, which are microphilia, enter the blood at night. And how we diagnose it? We diagnose with complement fixation test in the presence of, which will show either present or past infection. And if you take blood, so you can find out there will be eosinophilia, and this infection, once confirmed, can be controlled by diethyl carbamazine. It destroys the parasite, but if it is detected at very early stage, it cannot reverse the lymphedema. Lymphedema has different treatment, but it will control, this drug will control infection. Now, the better thing is to prevent those areas, reduce mosquito breeding, protective clothing, and mosquito netting should be practiced. This is how patients present with features of filariasis: fever, headache, malaise, inguinal and axillary lymphadenitis, lymphangitis, cellulitis, In chronic cases, they will present with all these symptoms of fever, and along with it, there's acute and chronic. So lymphedema will be there, hydrocele, and different lymphadenopathy will be there. How you will diagnose? You will diagnose with complete fixation test and filaria in the microfilaria in the blood culture. Now this is all about lymphedema. Now, once you have find a patient, you took history, you examined, you find those all findings which you have discussed. Now, next stage is to do surgery of that patient. But before surgery, you again want to exclude the causes which are treatable causes, like if there is cardiac cause, if there is a renal cause, or there are infective causes, deep vein thrombosis. So for that, first you do screening, like baseline investigation, full blood count, electrolytes, liver function test, thyroid function test, albumin level of the body, and urine pharmacouria. Urine pharmacouria. Why urine pharmacouria? Because if there is, it will definitely show that there is excess chyle is coming up in the, and there is, it has some communication with the bladder or renal system. Look for blood smear for microfilaria to find out whether it is caused by the which are Bancrofty, and chest radiograph and ultrasound for the to look for the any activity. This is again lymphangographic pattern of primary lymphedema. This is normal one. You can see both symmetrical lymphatic channels, and then there are lymph nodes, and this is the thoracic duct, and then there congenital hyperplasia on one side, distal obliteration of the obliteration by aplasia of the channels, proximal obliteration, and then the distal and proximal obliteration. So this is will be picture and lymphangographic when you do lymphangography of these patients. Now, previously the lymphangography was practiced, but now it's become obsolete because many other better investigation techniques has been evolved over the time. So now isotope lymphoscintigraphy is performed. In this, a radioactio-technetium level protein or colloid particle are injected into the interdigital space, which is taken by the lymphatic and then detected by the gamma camera. Now it provides a qualitative measure of lymphatic function. If you can see that isotope is going up into the leg, so it will show qualitative, means it shows function. But if you want to know the quantitative, how much it has went, so then you will add dynamic part of this. That you will inject this and ask the patient to do some exercises, so it will show a complete picture of the different channels. Now this is a lymphoscintigraphy of the patient. After 30 minutes, you can compare both legs, that how much it is went on the left side and how much on the right side, and after 2 hours and after 6 hours, almost it has been drained from here as well to the vascular system. So it's practice, the lymphoscintigraphy is practiced instead of lymphangography. Now this is a picture I was showing, I was asking you that where it is. You can see the muscle characteristically abnormal, only there is, you can see this honeycomb reticular pattern. It is lying in the epiphyseal. The lymphatic channels and lymph is lying in the epiphyseal area of the leg. Now this is at thigh level. You can see the femur here. Apart from lymphoscintigraphy, we can also advise magnetic resonance MRI, which will show classical circumferential reticular pattern, which we have just seen in that picture, within epiphyseal compartment. Involvement of the subfacial compartment is more suggestive of venous diseases. In lipoderma, fat deposition is subcutaneous tissue without the typical reticular pattern. So this MRI can, or even CT scan can help us to exclude lipoderma and if there's some venous problem. Ultrasound it's a basic investigation, will show whether there is, especially duplex ultrasound, whether there is DVT or not. Now this is something confirmatory. You will, if you suspect that there are nodules and there is a thickening. So if you take biopsy, or if there are lymph nodes are there, so if you take biopsy, it will show whether it is lymphosarcoma or other malignancy or just simple lymphedema. So today we have discussed what is lymphedema. There is classifications and pathology and investigation. Next time, inshallah, we'll discuss its treatment. Thank you very much. If you have any question, you can text through the WhatsApp. Allah Hafiz.